We open with case of 36-year-old female who was newly diagnosed in January this year with chronic alcoholic pancreatitis. She presented with belly pain, nausea, vomiting, and during the diagnostic follow-up, CT scan was performed showing a bulky pseudocyst 9 to 9 centimeters, compressing the duodenum, liver, gallbladder, and common bile duct. And now will be showed endosconographically guided drainage of this pseudocyst. It will be performed by Professor Binmoeller in assistance with Professor Reichert. And we will talk about the indications for pancreatic pseudocyst drainage and the technique of drainage using lumen-apposing stent. Now to the endoscopy room.
Yes.
All right, well, welcome back. And my pleasure to be here with Stan. It's a reunion for me because we know each other for over 2 decades. We first met in Hamburg at Nipse Hender's unit over 20 years ago. I'm also assisted by Hannah. So I want to always go back to the fundamentals. It's called endoscopic ultrasound. So the first word is endoscopic. So I'm not going to switch on the EUS yet. I just want you to look at the endoscopic image because using this oblique scanning echo endoscope, it's a therapeutic channel so that we can perform EUS-guided cyst drainage if indicated. But we get a beautiful view here of the stomach as we push in. And you'll notice in the upper stomach, we don't see any bulge or so, no deformity. But as we push down towards the antrum, you can already appreciate there is extrinsic compression along the posterior wall. So this is likely where the cyst is. In the old days, we used to drain these just under endoscopic guidance, which is certainly a possibility. But now with EUS, we can have the ability to be able to guide everything with endoscopic ultrasound. Because of this deformity, it's a little bit more difficult getting into the bulb, so I'm going to very carefully negotiate my way and look here in the bulb how this collection is compressing the duodenal bulb. So this explains her nausea and vomiting. It also explains why her bilirubin is elevated 5 times normal, and I noticed talking to her that she is developing some scleral icterus. So there's likely compression of her bile duct. Now, I'm going to stop right here and we'll switch now to the endoscopic ultrasound to look to see what's behind this bulge that we see. And now with EUS, you can see what is causing this compression. And it looks very different from what you saw on the CT scan. EUS, the ultrasound image now, gives us a much more granular definition of the contents. So what we want to look at are the contents and the wall and interrogate all of that before we proceed with drainage. What I can tell you right now is this is not fluid. It's not just fluid. There is definitely something inside. And there really are the differential, I think, the likely content would be blood, old blood. Typically looks like this, little echogenic with, you can see these little areas of anechogenicity, almost like cysts inside of it. And you can see there's heterogeneity in some parts here. And I think that is old blood, clotted blood with, different levels of aging of the blood clot. Now, the other thing in the differential would be infection, but she has no fever. Her white count is not elevated, but it could also be infection. Obviously, you have to think of other things in the differential. Could this be a neoplastic cyst? Could this be a mucinous cyst adenoma, a serous cyst adenoma? All these things are in the differential. But her history is strongly consistent with a pseudocyst that in which there has been some bleeding. So now we're going to interrogate the wall. I only have 15 minutes, so we're going to mag up a little bit here. And we're just going to throw on the Doppler, and we're going to look at the wall to look to see if there are any interposed vessels. So we're going to bring the Doppler up high We're going to mag up a little bit, so we just focus on the wall now. So I'm interrogating the wall, looking for any vessels. My plan is to place a 20 millimeter LAMS, axial stent. Why a 20 millimeter? Because I want to be able to go inside, and I want to be able to enable this clot and old blood to drain. So I want to go in there and really be certain of the diagnosis. So I need to be sure that on both sides of my puncture path, I have no vessels. If I use a 20 millimeter LAMS, then we're talking about 30 millimeters on both on total. So 15 millimeters on both sides. So I'm just going to go back and forth like this, looking to see if there are any obvious vessels. I think this looks pretty good. So let's take the Doppler off now. Let's decrease the magnification. I think this is a good window. But before I puncture, I just want to be sure that I'm not placing the LAMS too close to the pylorus. Because if I do that, then I may actually exacerbate the obstruction if the LAMS is right in front of the pylorus. So with the endoscopic view, I'm just going to turn, give a little bit of gas, just to confirm that I'm not at the pylorus. It's very easy to misjudge the position of the tip of your scope because the transducer is on the very, very tip. So your device is coming out a little bit more proximal to where the transducer is. So you may think it's great position for your drainage, but you want to be sure that you're not placing the LAMS too far proximal. All right, I think we're ready to go now. So let's insert the sheath. This is hydrophilic coated, which means that you wet it down before you pass it down so that you have minimal resistance. So it's important that you never push against resistance. And because we're in the duodenal bulb, it's possible that we may have to pull back into the stomach to advance. Well, let's see. Maybe it'll go through. So I'm very slowly advancing forward. You can see that hopefully with the camera. All right, it's going smoothly so far. And I'm in. Good. So I didn't have any resistance, and I'm going to lure lock now. It's a swivel lure lock, which allows me to visualize the handle, and I see there are 4 numbers, 1, 2, 3, 4. So if I get confused or flustered, I can always look at the numbers to guide me. She's not going to put this on until I tell her to make it hot. So the first thing I'm going to do is now I'm going to look at the EOS. I'm going to unlock, and I see the number 1 pointed down. I see that the gray hub is coupled with the black hub. The two are coupled. You can see that with this yellow pin here. So that couples the two together. So when I advance forward, I'm advancing the sheath forward. And now on the EOS, I'm going to look for the tip. You see the tip now? There it is. And I don't want to push in too far, just gently touching the surface. And I think this is a good position. I see the trajectory. This is a large cyst. I'm using a 20 millimeter LAMS. So I have to have at least 4 centimeters of runway to completely deploy my distal flange. If you want, you can measure that out, but I can already tell you this is definitely 4 centimeters, right? So there should be no problem in terms of having enough room, enough runway to deploy the distal flange. Now I'm ready to make it hot. So now Hannah is going to attach the cable. We are hot now. So we're energized. Okay, and now I'm ready. So I'm going to step on the yellow pedal. I have my settings, which are auto cut or pure cut, effect 5, 100 watts. Those are the standard settings. And I've confirmed that. And this is not an FNA. This is a puncture of a pseudocyst. So I use the acronym SSS, which is slow, steady, smooth. The most important is the slow. So I'm pushing gently here, and I'm stepping on the yellow pedal, and I'm slowly going in. There it is. I can follow it as I push it all the way in like this. I can see the very tip of it. I'm pushing in. Good. You can see the black hub is already all the way forward. I'm going to now lock. I'm going to take off the yellow safety pin, right? So the yellow safety pin is off, which uncouples the gray hub and the black hub. And the black hub is locked. So it's always alternating lock and unlock. So I've locked the black hub so that the inner catheter, which holds the LAMS in a tray, the axials, so that does not move. So now I'm only pulling back the gray hub, which pulls the sheath back to deploy the distal flange. I have my eyes glued on the ultrasound screen. I'm not going to look at the endoscopic. We have no fluoro here. None of us are leaded. This is all EUS guided. I'm going to very slowly pull back, and as I pull back, I'm going to look for the deployment of the distal flange, and I'm going to listen for a click that indicates when the distal flange has been fully deployed. So I'm just slowly pulling back, and I'm just giving this time, allowing that distal flange to open up. Now remember, the contents are not fluid. I think this is old blood. Therefore, it's going to take a little bit more time for that distal flange to open up completely. Especially when you have a lot of necroses, this may take a long time. So just give it some time. So the emphasis is on slow here. And now we can unlock the black hub. The gray hub auto-locked, and I heard the click. So I don't have to worry about locking the gray hub. And now I can snug up. That means pull back the black hub using it like a retractor. So I can pull it all the way back. You can see the cable is in the middle, that line. It's very echogenic. I can see the very tip, and there's actually something called the black mark, which you can see on the sheath endoscopically, but also with ultrasound. So I'm just pulling back until I see a little bit of asymmetry. So you can see now there's less on the left side compared to the right side. So the arrow is showing the left side. It's a little bit less than on the right side. That means I'm in perfect position. All right, so now I am ready to deploy the proximal flange inside the working channel. All right, so now I'm going to unlock the gray. I've locked the black. I'm just going to pull back slowly, keeping my eye on the ultrasound, making sure that that distal flange does not jump forward. So I'm just pulling back slowly. Wait until it's completely deployed in the working channel. Now it's in the working channel. Now I'm going to switch to the endoscopic view. And let's have the endoscopic large. And I am going to now push the proximal flange out of the working channel. But as I'm doing that, I'm backing off from the wall and I'm insufflating gas. And it's a slight turn to the right. My body turns to the right. And I'm giving some gas. I've unlocked. Oh, they disconnect the cable. I did forget to tell her as soon as you're in, you disconnect the cable. So that's very important. So you don't accidentally step on the cautery and go to the opposite wall. So now I'm pushing very slowly out. And I'm looking for, there it is. I'm pushing it out. And I'm going to use the gray hub to push it out completely. There it is. It just popped out. I'm going to keep it here for a moment. I want to make sure that I don't pull out the cable too fast because the nose cone is thick at the very tip and it can get caught inside of the saddle and you can accidentally dislodge the LAMS. So I'm just going to hold my position here, try to rotate my body a little bit, and very slowly pull back. But as I do this, I'm looking. Let's take the EUS. We don't need the EUS now. Okay, so that you can see it. I'm pulling back very slowly. It's always trickier in the bulb. When you do gallbladder drainage, you have to be very careful. And ideally, I want to rotate so I see the lumen, right? See how narrow that is there? So you can understand why if you just yank this out at an angle, you could pull out the LAMS. And that's happened too many, including myself. Okay, so now I'm pulling back slowly. See how there's resistance? So I have to be careful, pulling back. And I'm using my scope tip to keep the LAMS up against the wall. So I'm pulling back. There, it just came out. All right, so now you can see the LAMS in position here. Now, look what happened. It's actually much more proximal than I thought. I really had intended to place this completely within the bulb. And even though I looked and thought I was nicely in the bulb, I wasn't. I think it's partially because of all the deformity there. But you can see that this is sitting actually right in front of the pylorus. Now, it's not going to be a problem because thankfully I'm not blocking the pylorus, right? But you can see why it's so important to confirm where your LAMS is going to deploy. Now we're going to dilate the lumen with the CRE balloon. We're going to use a 15 to 18 CRE balloon, and we're going to dilate up the saddle. I'm also going to aspirate some fluid. We can put a trap on. We can collect that fluid and send it off for analysis. But you can see already that the fluid looks a little blood tinged, doesn't it?
Yes, as you expected. There was bleeding into the pseudocyst.
Yeah. So now Hannah has handed me the CRE balloon, and now under direct guidance, I'm going to pass the CRE balloon into.
So you do this procedure routinely without fluoroscopy?
Always. I don't think I can remember the last time I had to use fluoroscopy. Now, that's very different from some of the other axios procedures or drainage procedures. GEs, I always use fluoroscopy. Bile-duct, I always use fluoroscopy. Gallbladder, all depends on whether I want to inject to see if the cystic duct is patent. Now, you have two options. You do have a wire inside of this. So if you're coming at an angle, you can advance the wire out. So let's just try that with the wire first. There, it goes in nicely. I'm going to follow the wire. Okay, I'm pushing in. So remember, you don't want to risk dislodging the LAMS. So that's why I'm being so careful. So I'm just going to push in a distance, and then I'm going to start to back off. And now start to dilate, please. You can see the pink at the top. That's the end. Start to dilate to 15. That's the first step. And I'm going to try to keep myself as perpendicular to the axis as possible. Right? So I'm pushing in, and I'm pushing the balloon so it is it's in the axis of the saddle.
Amazing, Ken. Ed here. Thank you for that phenomenal demonstration by the master and the inventor himself. Ken, I'm going to be, asking you the question relating to the pylorus. So, what if when this expands fully, there is a degree of pyloric obstruction? I don't think there would be, as you said. What would you do to mitigate this?
Yeah. Well, I mean, if it became an issue that it really is obstructing, then I think you might just exchange out for some plastic stents. I mean, but I think this would be so rare. She's deflating now. I'm going to switch out for a gastroscope, and then I'm going to go inside. I'm going to use a therapeutic gastroscope, and we're just going to go inside and try to clean out as much as we can. So you inflated to 18, correct?
Yeah.
Okay, good. So I'm just pulling out to the maximum. And usually you can sort of look inside a little bit. But I'm just going to switch out now.
And we have to move to the next room.
Pass the therapeutic gastroscope through the 20 millimeter axios. And here you see the interior. I'm being very careful with gas. Even though it's CO2, you want to be very careful. And usually I do this underwater, but I want to demonstrate for you how we can apply what I call the magic gel. It's Puristat. So this is the 3D self-assembling protein that has hemostatic properties, but also tissue regenerative properties. And I've used this a number of times in patients with bleeding from pseudocysts or walled-off necroses, because remember, a pseudocyst has a pseudo wall, and the wall is lined with blood vessels. So you don't want to go in there with hot biopsy forceps, any coagulation devices. Purostat is really the ideal solution. So you should have this available in your unit when you're doing this. So now Hannah's going to start injecting. You're going to see the gel just sort of drip out here. So she's pushing this out. And I just want to have enough gas so you can see how it's a thick gel. And I'm just pushing down a little bit. And I'm just going to fill up this cavity like this, move it around a little bit. And I've had a few cases now that I've been able to treat very successfully with Purostat, with bleeding after doing necrosectomy, for example. And and it's actually quite a lot of gel that comes out of this. So we just have the assistant push out all of the gel. It just drips out. Another syringe full. And she'll let me know when it's all out, and then I just pull out. But I wanted you to see how there we see the remainder, and I just swivel it around. Oh, it just fell up for a moment. Let me just go back in quickly. Pull back. Just get the remainder of the Purostat out. Keep expelling. There it goes. There it goes. Very nice. So I think this is a beautiful modality. And obviously something that you want to use if you have any bleeding. But I think the question is whether it may also help with regenerating after drainage, regenerating the tissue, restoring the normal epithelium. So for out, then I think we can just pull out now. And I'll pull out the gas, and we're done with this procedure.
Thank you, Kenneth, for outstanding presentation. And we have to move to the poem.